Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome back to another episode on the Health Trip Podcast. Perimenopause is a transitional phase that marks the beginning of a woman's journey towards menopause, often starting in the late 40s, but could start as early as the mid-30s. As hormone levels, particularly estrogen and progesterone, begin to fluctuate, women experience a variety of symptoms, including weight gain. This weight gain is often due to hormonal changes that affect our metabolism, insulin sensitivity, and fat distribution, particularly around our abdomen. This weight gain during perimenopause not only affects physical appearance and one's confidence, but also has important implications for long-term health and longevity. Increased abdominal fat is linked to a higher risk of cardiovascular disease, type 2 diabetes, and metabolic syndrome, conditions that can significantly impact a woman's quality of life and lifespan. Addressing weight gain during perimenopause is not just about aesthetics, it's about prioritizing long-term health. Making mindful, sustainable lifestyle changes can improve not only how women feel today, but also enhance their longevity, supporting a more vibrant, healthy future. Health coaches can help you on your menopause journey to figure out what your unique health equation is alongside your doctors. My guest today is Dr. Heather Quayle, who is a double board certified women's and gender health nurse practitioner and advanced forensic nurse specializing in human trafficking and female sexual health. She is a thought leader and creator of the Just Ask podcast. She is also trained and certified as a Menopause Society certified practitioner and has been working in all aspects of women's healthcare for over 23 years, caring for women of all ages across the health illness continuum, and recognize the lack of sexual health awareness, not just in her community, but in its providers. She founded, developed, and implemented her private practice, the Sexual Health Optimization and Wellness, it's called SHOW Center. Her goal is to help guide patients through their healthcare journey and provide a range of services that address the biopsychosocial aspects of health, wellness, optimization, and sexuality. She is passionate about changing the systems and beliefs that have stigmatized women's health and female sexuality through a non-judgmental, empathetic approach grounded in evidence-based research. She is a fellow of the International Society for the Study of Women's Sexual Health, otherwise known as ISWISH, and a fellow of the American Academy of Nurse Practitioners. So ladies, we are in very good hands in terms of talking about why weight gain is happening in the first place during this period of our lives and strategies to help mitigate it. A short medical disclaimer before we continue. By listening to this product, you agree not to use this podcast as medical advice or to make any lifestyle changes to treat any medical condition in yourself or others. Consult your own physician for any medical issues that you may be having. This entire disclaimer also applies to any of my guests on my podcast. So sit back, open your mind, and let's dive in. Hey, Heather, welcome to the Health Trip Podcast.
Thank you so much for having me.
I'm really excited to have you here today. One is I don't necessarily hone in on perimenopause, and I haven't really devoted a podcast episode to weight gain and menopausal women. So I think we're going to check off a lot of boxes for a lot of the women listening.
Wonderful, wonderful. Can't wait.
So let's just start digging into what perimenopause is first. Set the stage for this time in a woman's life.
Yeah, absolutely. So perimenopause is that time frame before menopause. So the average age of menopause is right around 51 and a half to 52, but the perimenopause timeframe can happen several years prior. On average, it's about 4 to 7 years prior, but for some, it could be longer, it could be shorter, and it may come as early as like late 30s, early 40s. And it's kind of that time frame that we call that just zone of chaos. It's when most patients are experiencing most of their symptoms. An increase in hot flashes, the night sweats, the mood changes, the brain fog, and all the different things as estrogen and progesterone start to decline. So I usually kind of say the average is mid 40s, but again, it just depends really person to person.
Yeah, looking back on my journey, I'm 56 now, but when I was 45, I did a post last week on my perimenopause journey, and man, I had probably put on 10 pounds out of nowhere. And I am someone who has always been lean and strong and very active my entire life. And looking at that picture, it's like I don't even recognize that person. I have since, figured out, with working with a provider, what to do for myself. But back then, I really had no idea.
Yeah, and a lot of us don't because no one ever really wanted to talk about it. It is always kind of the thing, like our moms, sisters, aunts, whatever, grandmothers, kind of that silent time. So sometimes we don't have a good gauge on what family members went through. So it's kind of like the not talked about thing. So very,
Yeah.
very common thing I see, unfortunately, a lot at my practice.
And it causes so much um, anxiety and even depression in women because they think to themselves, where am I failing myself, right? What am
Exactly.
I doing wrong that's causing this out of the blue? My jeans are no longer fitting me. I am not sleeping well. And so we start to have more low self-confidence, which is a symptom, but not really one on the list.
Exactly, very much so. And you're kind of questioning because you may go to your healthcare provider, you may just have a primary that you see, and you may just say,
Mhm.
I'm not feeling like myself. I'm feeling a little bit off. And then they tell you, oh, it's fine, you're normal, your labs look normal, everything looks good. Why don't you try an antidepressant? And so women often feel really dismissed. Some women even get gaslit when they try to go to their healthcare provider. And I think that makes it a really challenging time frame too, because you're like, I know I'm not feeling better.
What do you recommend for a woman listening to you saying that right now, who's working with a provider? Maybe they've been going to since, maybe it's the same provider who delivered their babies, right? And now all of a sudden she's in a different phase of her life and her doctor isn't really listening. What are some strategies that you can offer that woman right now?
So I always say if you can get some lab work, it's great. I'm not this huge lab chaser, but a lot of times if you are symptomatic and you're experiencing hot flashes, night sweats, brain fog, maybe some weight changes, mood changes that are thrown in there, it's really time to go in, talk to your provider, and have someone that's going to listen to you. If you're finding that they aren't listening to you, then it may be time to go look for a different healthcare provider. It's really, really unfortunate that a lot of times people have to navigate outside of the insurance-based models. And part of it is because you cannot do menopause care properly, especially perimenopause, because it's such a chaotic time in a woman's life, in a 15-minute appointment, by the way, at the time of their annual. So if you have a healthcare provider that may be able to give you a problem visit, or you go in outside of that and do a copay, that's great. But if you find they aren't listening, then I really do suggest following up with someone who may see you out of network, and then maybe submit a bill to insurance for out of network. You can look at the Menopause Society for providers. And then, of course, there are plenty of people that are online in the social media spaces that I highly recommend following. People like Dr. Corinne Menn, Dr. Mary Claire Haver, Dr. Heidi Flagg, myself, Jacqueline Piasta. We all really try to put a lot of wonderful evidence-based information that's out there. And if you start kind of following some of the people I've mentioned, you're going to follow other people that try to put that out there as well.
Yeah, that's a great strategy. How does hormonal changes affect weight gain that women are experiencing? So you mentioned that there's these fluctuations, and can you just dive in a little deeper on that?
Yeah, so estrogen is really kind of almost this anti-inflammatory hormone, if you will. It kind of keeps things in check. And it's why I often see women have changes in their body composition, maybe some changes in their cholesterol numbers. So I see a lot of patients that are like toting along normal, and then they start going through this time frame of change, and they may start seeing some rises in their cholesterol level or in their LDL levels out of nowhere. And they're like, my family history is stable, nothing I can think about. And so a lot of it is just these hormonal changes that start to happen. Your estrogen starts to deplete, and so you start developing more of that mid-abdominal belly adiposity, changes in our body composition. Maybe you're more fatigued, you're not sleeping as well. If you were an avid exerciser, you just don't have that energy to exercise like you were in the past. And so that almost compounds on leading to a lot of just the weight and body changes that start to happen during this time.
So you mentioned this adiposity, this belly fat that a lot of women experience. I certainly did. And that is very much different than visceral fat. And is at the same time visceral fat also building around our organs at the same time as this adipose fat is increasing? Or not
Yes.
necessarily?
Yes, absolutely. So that is, I talk a lot about just this visceral fat change. It's why I really try to do a body composition scale on patients. So the scale that I use in office is called an in-body scale, and what it uses is it looks at your skeletal muscle mass, it looks at your percentage of body water, your percentage of body fat, as well as a BMI, which I hate BMI. I think it's a really poor indicator because it's just an equation that they've come up with, and it's just not an ideal equation, but it looks at all these different metrics. But one of the things it also looks at is visceral fat. For your listeners who don't know, visceral fat is the fat that kind of surrounds those organ tissues. And we want that number, especially when we're using like in body, for example, we want that number to be under 10. So things that as your body starts to change, as your hormones start to deplete, you start to experience more visceral fat around your heart, around your organs, and that leads to more cardiovascular disease. So really kind of clean eating, more fiber in our diets, all the things that we should be kind of talking about with our patients are really going to kind of help those visceral fat and changes that are going on while your hormones are kind of depleting more and more in your body. And then, of course, obviously supplementing hormones when you are having these changes going on. I'm never going to tell someone that, here, I'm going to put you on hormones and it's going to help you lose all of this weight. I'm not going to say that it's not a weight loss medication, but when you use things in your wheelhouse and have your hormones in check, it makes it easier for the weight to come off. So, for example, if you're eating healthy, you're exercising, you're doing all the right things, and your hormones and maybe your thyroid are completely out of whack, balancing those out will help the good changes you're making. And then I do have a lot of patients that use the GLP-1 peptides like the Ozempic and the Wegovy and and Mounjaro and tirzepatide, all those different meds. Those don't work as optimal when you are not having your hormones in balance and your thyroid in balance as well too.
Yeah. I was going to ask you this later down the road here, but we're here right now. So I thought maybe we'd tackle it. Talking about the guidelines for women in perimenopause when it comes to taking menopause therapy, right? There's a lot of myths or misconceptions out there, misinformation about when you can actually start. Some women have been told by their providers that they need to be done with their 1 year out of their last period before they can start taking anything. While we know that that is not necessarily true. And then who is a candidate and who would not be a candidate? If you could just cover some of that.
Yeah. So basically, the way that I kind of look at things during this time is that absolutely you can take hormones. I think part of the problem is that you hear these things like, "Oh my gosh, you're in perimenopause or you're in this weird function in time and you can't take anything until you completely stop bleeding." Well, that's completely wrong. You can still have regular to irregular periods and absolutely still have all the changes going on in perimenopause. So I like to kind of gauge perimenopause as either kind of like this late and early perimenopause. And early means that patients are usually kind of having some changes going on. Their periods may still be somewhat normal. Maybe there's a 5 to 7 day duration of change. So maybe 1 month you bleed at 30 days, the next month it may be 32 days, the next month it's 37, and then it's back to 30, but some variability. month to month. It's kind of that early perimenopause timeframe. The later perimenopause timeframe is usually if you're going 60 days or longer between your cycles. And so you're going to hear lots of schools of thought. Sure, you absolutely can take a birth control pill, and that's going to control some of the symptoms of perimenopause because it's going to put hormones back in your system. It's also there if you actually need something for birth control purposes, but it's usually not going to be a first line option that I offer my patients. I kind of wear a hat as a sexual medicine provider, so I do a lot of sexual health and dysfunction at my practice. So I have a major love hate relationship with the birth control. I think that it affects libido. I think it affects vaginal and vulvar changes that are going on in a woman's vagina and makes things drier and more irritated. So, oftentimes, I'm going to offer women in perimenopause hormone therapy. So, that's going to look like something that is bioidentical to what we produce in our own body, but it's an FDA approved option. So, it may be a patch, it may be a gel, and it may be an oral form of something like an estradiol, like what we make in our ovaries. And then I'm going to usually offer them something like a micronized progesterone, which is bioidentical to the progesterone that we also produce in our body. And kind of during this fluctuating time, most of the time in perimenopause, the first hormone that's really going to start to deplete is that progesterone level. And most of my patients I can manage in the early perimenopause with just progesterone only. It
Mhm.
usually is something that I give at nighttime. Progesterone works really nicely on the GABA receptors in the brain, so it causes this very calming effect. So for my patients that don't sleep well, or they have a hard time falling asleep or staying asleep, it usually helps a lot of those symptoms. And then in that early perimenopause time, it really also helps a lot of the hot flashes and night sweats. Then, as we get farther along and cut a little bit farther out, maybe some later perimenopause or closer to menopause, we may need to add in some estrogen. The other thing I want to kind of add in is that hormone replacement therapy is not going to be birth control protective. So, a lot of
Yeah.
times we will need to figure out, does a patient need birth control? Another option is to use it with an IUD, like a Mirena IUD, because it keeps the lining very thin. So, there are so many different options we can do for perimenopause, and I don't think it's you need to stand for an answer of you need to stop bleeding before we can start something because that's not true.
And what about progesterone cycling? I remember when, it was 10 years ago, my doctor at the time had me start to cycle where I just used it 2 weeks out of the month. And then of course we ramped it up to every night. And then as you're talking about, we started the estradiol later on down the road when I got closer to menopause. But what is the significance of progesterone cycling? Is it still a thing? Is it still necessary?
Yeah, some people will do it as cycling. I have some patients that swear that's how they want to do it. That's how they feel better. And
Hmm.
I really let patients have a say in the matter. It's their body, their choice. I'm there to kind of guide them in the
Hmm.
decision making. I personally prefer it better that patients take it every single day or every single night because it has that nice effect on the GABA receptors. So they sleep
Yeah.
a whole lot better. They also don't forget. I also find in this time frame,
Hmm.
a lot of my patients come to me with word recall issues, brain fog, their brain is just not where it used to be. And so telling someone, okay, you got to remember this cyclically throughout the month. Let's be honest, if you are a working woman, you're raising kids, you're trying to keep a clean house, be a wife, be a friend, and all the things, who the hell remembers to take their progesterone
Yeah.
14 days or 12 days out of the month? So my mentality is just take it every single day.
Yeah, that's such a good point. What about testosterone?
So, yes, 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 and yes. I'm a huge advocate of testosterone. Unfortunately, as females, we kind of have the bum end of the stick. We have nothing that is FDA approved for libido. The only thing that we have a use of for libido are two things. We have two FDA approved products for females for libido. One is a little pink pill called Addyi, and the other one is an injectable called um, bremelanotide, and we can talk more about that if you want, but let's get back to testosterone. Testosterone is not FDA approved for females, but we have a consensus guideline that was put out from the International Society for the Study of Women's Sexual Health, as well as the Menopause Society and the American Urologic Society, where we've all said in the societal consensus algorithm that you can use testosterone for females postmenopausally for libido changes. So here's my take on this in a nutshell. We use a lot of meds off label. I think it's really frustrating that when we want to use things off label for women or especially hormones in general in an off label fashion, you get a lot of pushback. So, testosterone is not FDA approved. We use it for postmenopausal women. We have a consensus guideline that gives us that for testosterone. I absolutely see increases in libido and good changes with it. But I also will use it off label in my perimenopausal patients. And we don't have enough data, but there is some good data out there that shows in males that it really does help brain health. It helps joints. And so often when I counsel my patients, I tell them this is FDA approved for nothing, but we have it for libido. And you may get some secondary benefits where it may help some joint pain that you're having. It may have you have a clearer mind. I have patients that call it the CEO hormone, that it just makes them feel that
Mhm.
their executive functioning is better. So I have a lot of wonderful anecdotal um, things that patients have told me over my multiple years of practice. We just need more good data on it. But I think it's a wonderful adjunct to your hormone repertoire. And I usually will add that in once I get the estrogen and progesterone stable.
Yeah, I want to get your thoughts on this with testosterone. So I've been on testosterone for, I don't know, at least 10 years. And it is something that has given me back not only my libido, but my zest for life, for sure. But
Mhm.
one of the things that also has happened to me, which I believe happens to a lot of other women, is it can trigger hair loss if genetically you're predisposed to something like androgenetic alopecia, or if you're genetically predisposed to high DHT, dihydrotestosterone levels. And so these are things that I had myself look at genetically because I was experiencing hair loss when I started taking testosterone. Um, and I just wanted to get your thoughts because so many people, so many providers in this menopause space say you don't need to test. I know that you already said testing for blood work and certain biomarkers can be very helpful in this journey. But with testosterone, I think it's a really smart idea. I am not a provider, I am a health coach, but I just know from my own journey that looking at what levels triggered my hair loss and how to mitigate that was really helpful for me.
Absolutely. And I think part of it, I'm not going to get into a whole lot of levels because it's all over the map.
Yeah.
I would just say I try to stay in a range that's under 80 nanograms per deciliter, but I have an equation that I kind of use that the guru of medicine, sex medicine, Dr. Irwin Goldstein, kind of told me as like a little gauge on that. I also use testosterone more in a cream formulation for my
Mhm.
patients and get pretty good results rather than a pellet or an injectable form. There are pellets. I feel like the pellets done a really bad disservice to women in this market. I think that there should be more evidence-based information, if there could be, on pellets and injectables, because for some women it works okay. But the problem is we use them in such exorbitantly high doses. So when you go to these pellet factories, they shoot you up with these pellets every 3 months. They put in way too high of a level. And so you have this like roller coaster effect that's going on with these women. And so, of course, that's going to lead to more mood changes. It may lead to like this great libido and plummeting libido. I've seen enlargement in clitoris, I've seen hair changes. And so I feel like when we try to keep it at 1/10 of the female dose and set very realistic expectations, I think that we can mitigate hair loss, but I also think that when it gets too high, 100% it can lead to hair changes. And I think it's also important that when you are going to a provider that is giving you your hormones, get everything in check. Usually it's the last hormone I add. And you also want to make sure you're getting like a really good thyroid panel.
Yeah.
And all those different things.
Mhm.
What I said before is I'm not a blood chaser. Usually I'm going to get hormones at your first visit because I like to see where baseline is. And then when patients come to me still symptomatic and they've been, let's say, on an estrogen patch and I don't know if they're absorbing, of course, I'm going to check hormones again and see what the absorption may look like in my postmenopausal patients. But testosterone is a little bit different. I'm very OCD about getting labs. I get a baseline. I recheck the labs at the 4 to 6 week mark with initiation of testosterone. And then I check it again at 3 months. And then I somewhere check it between at least every 3 to 6 months on every single one of my patients, as long as they're on the medication. Because again, you want to make sure that you're getting the effect. You want to make sure it's not getting too high. And then I think the other thing that's really important is you want to make sure that the patient is using it properly. Like what I find a lot of times is that patients don't always use their medications properly, in particular creams and things. And so I'll often bring
Yeah.
it back and say, let's have a conversation how you're using this medication, and are we using it properly, and are we putting it on the proper places and things like that.
Yeah. Yeah. I'm so glad to hear you say that, because what you're saying, the protocol you're talking about is the protocol that I've been following for many, many years. And I'm constantly looking at, I have a partial thyroid. I only have half a thyroid. So I'm constantly looking at very specific labs. I always like to say everybody has a very unique health equation, and that goes for your relationship with your provider and the labs that you're getting more often than other labs. So I'm glad to hear you say that. I want to circle back to how hormonal changes affect weight and talk about the slowing of our metabolism and muscle mass loss. This is a time in women's lives where they start to panic and, like I said, have an increased level of anxiety, possibly depression, because they are experiencing these physiological changes. Their clothes aren't fitting them well. They're just not feeling as good about themselves from the outside. And then, of course, the changes on the inside. And this is when they start making decisions that might not be beneficial, such as restricting certain lifestyle interventions. So maybe they're exercising too much, or they're restricting calories. Maybe they're over fasting, not getting enough, not prioritizing sleep, maybe having a little bit too much wine because that's helping them chill out at the end of the day. And these lead to a lot of downstream adverse consequences. One of those are nutrient deficiencies, loss of lean muscle mass. What else are you seeing going on, and how this time is affecting women?
So what I find in this time frame, and I take myself personally at this. So like I'm an entrepreneur. I'm raising three grown, well, almost grown children. My youngest being 16, my oldest being 23. So I say adult kids, adult problems. I run my practice. I'm a menopausal woman. I've had all the weight things. So it's like I'm a guinea pig for my patients all the time. I'm like, been there, done that. We're
Mhm.
kind of at this point in our life where life should start to be getting a little bit easier, but I think we put more demands on ourselves as females. Maybe we stayed home and raised our kids, or maybe we worked part-time or things like this, but you hit this time frame of your life, and most women are at the peaks of their careers in a lot of places. So when you're at a peak in your career, for example, maybe you are an entrepreneur, or maybe you're a CEO of a company or some other things, the expectations of you as a female, you want to stay on the same level playing ground as your colleagues, in particular our male counterparts. And that's why we can even talk about menopause in the workplace and why we need to do a lot
Yeah.
better on it. But we hit this peak in our career time. And so we put a lot more pressure on ourselves. And so with the pressure comes the decline in maybe not being able to exercise as often as we want to. A lot of us need exercise, just not even for the purpose of just strength training and bone health and all those things, but some of us need it for stress reduction, and we kind of put it on the back burner. The other thing, that I see during this time frame is, like you said, people may be making some poor choices, like I need some wine to settle down, or I'm not sleeping as well. Maybe the wine will unwind me, or maybe I need a CBD product, or maybe something with THC, and starting to make some really bad habits because we sleep.
Mhm.
And I always say, like, when sleep is not winning that equation, everything else falls off the wayside. So when you aren't getting optimal sleep because you're burning the candle at all ends with work and job and home and everything else, sleep declines. And so then again, that's going to raise a lot of those appetite things, like you have in here, like the ghrelin, the leptin, all the things leading to insulin resistance. Insulin resistance is a big thing that I see problems in my midlife women, is they are just not utilizing their insulin as properly. So more of that mid-abdominal belly fat, they're not working out as much. So they start to have some just changes in their weight structure. They are that, and then again, increased stress, the poor sleep, the poor habits, the alcohol, all the things. And when you look at that as a whole, then that leads to increased risk, cardiovascular change, diabetes, Alzheimer, all the things that kind of go hand in hand when we aren't taking care of our body. The other thing I tend to see too is a lot of women try to intermittent fast, and that it has some benefits, but for some people it's not the be all end all. And so you're in this calorie restriction mode. And I tell this to a lot of my weight loss patients when we go into calorie deficit, especially a lot of people using these GLP-1s, which I want to get into a little bit.
Yeah.
You're just not eating enough calories. So then your body's going to go back to a regulation point and be like, I'm holding on to everything because you're not putting enough calories in. And I need to maintain life so that you can go to work, be a mom, do everything else that you need to do in life. And so it kind of returns to this set point and it just gets into this vicious cycle.
Yeah, let's talk about the GLP-1s. I think that's a really important topic. There was a study that was done on women who use menopause hormone therapy and GLP-1s at the same time. And what they saw was that in terms of weight loss, there was a additional protection of bone health. I don't know if you saw this study or not, but I thought that was really fascinating because when people do take GLP-1s, the the right candidate with the right provider, doing it the correct way, they have a loss of appetite. Their motility slows down, so they feel fuller for longer. They don't seek food out like they used to. I've even heard people say that they've gotten really weird cravings on these drugs where it's not that they're craving healthy food, they're craving, junk food in a way. And so we know that they're not getting the essential nutrients that they need and they're not eating as much. So I thought this was a really interesting study showing that it protected the bones because we know we need nutrition, specific nutrition for bone protection.
Yep. So we actually did a podcast in my podcast on the Just Ask podcast about that actual study that showed that menopause hormone therapy, when your hormones are in check with using GLPs, had really good beneficial effects. I think, again, it comes down to my bias. You need to find a good provider, not these doc in the boxes that are going to throw you your GLP-1s and say, here you go, lose your weight. It's great. You don't really need an appointment. So when I look at my patients as a whole, in particular women that come see me for GLP-1s, first of all, blood work is mandatory at my clinic. So I'm going to look at your cholesterol. I'm going to look if you're insulin resistant. I'm going to look at your inflammation markers. We're going to look at blood chemistries, all those different things. I always will encourage my perimenopause and menopausal patients to also let me look at their hormone levels as well and get those in check. But I think the thing that we need to think about with these GLP-1 meds is they're very powerful tools if used properly. So I've been in women's health for over 2 decades now. And I'll be honest with you, Jill, I did not want to touch weight loss with a 10-foot pole for almost 20 years until these
Mm.
GLP-1 meds came out, because I think that a lot of the weight loss medications that have been out there have not been great. We have things like phentermine that cause a lot of like heart palpitations. Everyone gains the weight back, not realistic expectations. And of course, on these GLP-1s, yes, there is risk of weight gain, but I think that they are powerful tools in the toolbox, but they're not for everyone. So I'll walk you along kind of what a patient looks like in my clinic. And by the way, I
Yeah.
did this for myself and lost 60 pounds. So again, I am
Wow.
a guinea pig. I a lot of things hormonally and weight loss wise, unless I kind of try them on myself first before I try them on a patient, just to say,
Mhm.
like, is
Yeah.
it true? Is there evidence behind
Mhm.
it? So here's my take on GLP-1s. They were initially started as medications for diabetic patients, very powerful. And I believe it started off, it wasn't even liraglutide, but I'm forgetting which one it was. It was actually Saxenda, but that was not the first one, but it was an injectable that you did every single day. And then it moved to this weekly injectable, and there are oral forms. And what they saw in the diabetic patients is that on average, they were losing 10 to 15% of their body weight in a year. So what company is not going to capitalize on this? You know that weight loss, especially being in the coaching and nutrition part of your world, that
Mhm.
that is the biggest thing that women have concerns with. So company capitalizes on this. They come out with this weight loss drug, and now they can't even keep up with supply. So, what I see is that it is a great medicine to control blood sugar. It is a great medicine for the patient that wants to be mindful about how they lose weight. So, I don't like my patients losing more than between a half to 1 pound a week or so. And I think
Mhm.
that's realistic. I get these patients that come in, they're like, oh, but I want to be losing 2, 4, 5 pounds a week. And I said, first of all, it's not sustainable. And second of all, it leads to problems of sarcopenia and muscle wasting and osteoporosis. So, again, I try to keep their hormones in check. I use absolutely a body composition scale in my practice so that I can watch their percentage of body weight go down. But I also want to make sure I'm not losing skeletal muscle because I'm doing them no service if I'm taking a midlife woman and I'm getting them so skinny that they break their bones and and they have a hip fracture and they're in a wheelchair and they're immobile and all the things. And I think some of these doc in the boxes are, oh, let's go higher, higher, higher on doses. So I tend to keep my patients at a pretty low dose of this medication. I also implement protein and nutrition and regular blood work. And I think all of that are just really important pieces that a lot of these places are like, I just want to inject myself. I'm going to eat like crap and I'm not going to make the lifestyle changes. And I think that's important. Like, I really push for nutrition. And speaking to nutritionists, I don't ever put myself out there as this nutrition person because it's not my wheelhouse, but I refer quite a bit to nutrition to make sure that if and when you want to go off these medicines, if it's attainable, you have to have the lifestyle in check. And I think if you're telling patients you can lose the weight and go off of it, and they have 20 or greater pounds to lose, that's not realistic either. I think these medicines need to be used for the long term. I think they can be used in smaller amounts, smaller weight over time. And I think that you have to be putting the lifestyle in check. So I tell people you shouldn't be drinking tons of alcohol. This medicine makes you feel pretty gross. When you have those rush of sugar cravings or bad fit cravings and things, and I know I'm guilty of it sometimes, it's because it's a medicine that was initially made to control blood sugar. So when your blood sugar drops because you're not eating, because you're not hungry, you may go to the cabinet and grab something sugary, sweet, and junk food just to raise that blood sugar. So the meds also work on those dopamine receptors in the brain, so they calm the hunger chatter. I've had patients tell me they feel flatter on them. So I assess for any kind of depression, anxiety, suicide risk. So it's like there's so many things that need to be
Yeah.
taken into the equation when we do these meds. They are a powerful tool and they can be used very properly and very poorly.
So you mentioned long-term use, and there's all kinds of talk about can people come off these and sustain their lifestyle and sustain the weight loss. Well, you already shared with us that you lost 60 pounds while using. So are you microdosing, and is that something you'll be doing for the rest of your life?
I say you're going to apply, you are going to pry my hormones and my GLP meds out of my cold, dead hands. I do microdose. I take a very small dosage of the medication, and I do it somewhere between every 7 to 14 days. I'm very cognizant about my protein. I make sure my hormones are stable. I also find that when I'm in periods of stress, anxiety, maybe work-related stuff, adult children related stuff, like I don't make the best choices with my nutrition. And so it's something I always have to keep dialed in my head. So just like we try to keep ourselves healthy. Maybe we go to therapy, counseling. Like, I know for me, I'm insulin resistant. Weight has been a struggle my entire 51 years of life. And it's just the pieces that I need in my equation to make sure that I take a small dose and I eat healthy. Do I tell myself that I'm going to never ever drink or never have a sweet craving or anything? No. Sometimes I'll give in to my cravings, but I'm also really mindful. Like, pretty much a non-alcohol drinker. I wasn't before I started, but this has kind of kept it to where I have really no interest. So it's like those kind of lifestyle habits I think need to be in check.
Yeah, well, thank you for sharing your story. I think it's so important to hear it coming from a provider, especially who had the experience and who's continuing to have the experience and figure out your unique health equation, how you can manage staying on this and being successful, and then translating that down to all of your clients. So thank you for that. You mentioned insulin resistance a few times, and I was just wondering if you could explain what insulin resistance is. I think there's some listeners who maybe have not heard of that, and how perimenopause and the menopause transition affect someone from going from being insulin sensitive to insulin resistance.
Yes. So basically, what insulin resistance means is that when our cells in our body are just not responding properly to our insulin levels, we have hormones that regulate our blood sugar, and when we start either getting our blood sugar too high or too low, or different things that are going on, it just makes it so that our bodies don't respond as well. So when this happens, you start to see that you may start to lose some muscle, may get some fat changes that happen, and your liver and all those organs are just not responding as well to insulin. And so, what it does is it makes it so there's more circulating glucose in your body. And then, as a result, your pancreas tries to make more insulin so that it can kind of break down your glucose levels, and this kind of whole vicious triad starts to happen. So we know that estrogen is this anti-inflammatory hormone. So kind of by being anti-inflammatory, it has this whole cascading effect on our body, kind of keeping things in like this weight and balance. And so when that starts to deplete, sometimes our body will start making like it just is not breaking down our sugars as properly, and our insulin just we just become in this insulin resistance phase. So it's really important that we're getting lots of good fiber in our diet. We also want to make sure that we are using weightlifting exercises. We want to make sure that we are maximizing protein. I usually will say, and you're kind of that nutrition world, so correct me if I'm wrong. I know it's more than 100 grams a day, but I usually will tell most of my women patients, start with trying to get 80 to
Yeah.
100 grams of protein in your diet a day. Most women need more than that, but even getting, if you actually look at the protein intake of most women, we're not even touching that 80 number. So I usually try to say to kind of break their meals up so that they're getting protein in there. So like an egg has I think it's like 6 grams of protein, and people are like, "Oh, I ate an egg for breakfast. That should be
Right.
protein." And you're like, "Crap, that's only 6 grams of protein, and I need to get like 80 to 100." So supplementing with shakes and things to kind of keep those protein levels up is really important, because that too will kind of help this whole insulin resistance time frame as well too.
Yeah, I usually say 100 grams at the bare minimum. And then what we know from the literature is that if you're especially on a weight loss journey, to use 1 gram of protein per pound of ideal body weight. So if you're a 175-pound woman and your ideal body weight is 135, aim for 135 grams of protein per day. And I know that that sounds like so much. One of the strategies that I use with my clients is have them track 3 days for a week, just 3 days, right? Only track your protein and see where you are. Are you one of those women who's somewhere between 30 and 50 grams a day? Or are you already over 75 grams a day and don't have too far to go? Right. And then, so I think tracking is very valuable. I don't necessarily want people to be attached to tracking their calories or their grams. I want people to become an intuitive eater. And also, some people have a really bad relationship with tracking
Yeah.
food if they have disordered eating or from their past. But really looking at the data, and then that can help them make that decision and say, oh, wow, all right, this is in black and white. I'm eating 55 grams of protein a day. I'm nowhere near the bare minimum. What do I need to do? And I love your suggestion of protein powder, because that is so versatile. Can throw it into your yogurt smoothie, your yogurt parfait with berries. So there's a lot of great ideas in terms of using protein powder to supplement. Um, in terms of insulin resistance, what biomarkers do you look at? Because I work with a lot of women who show me their blood work, and maybe, there's always glucose on there, right? But that's it. That's where it stops. And I don't think that that really is giving the full story of their insulin resistance or insulin sensitivity status.
Yeah, so, I think, like, I do check an insulin level, on my patients, and we used to say that we used to give higher numbers, but I usually say somewhere, and this is kind of what the lab people have told me, somewhere between, like, an 8 and 9. Anything higher is putting you at risk for insulin resistance. So, again, I don't try to be this nutrition person. I often will refer. I usually will get blood work on my patients through a company called Quest Labs, because
Mhm.
they have a program called For My Heart. And it actually comes with um, a nutritionist that comes and works with the provider on how to get them to eat properly and all those healthy things. So I think it's important to look at insulin scores. I think it's also important to look at an high sensitivity C-reactive protein that also is going to look at inflammation that's going on in your body. Some people get homocysteine levels. I don't do a lot of that. I start to get a little wonky. If you start getting too much blood, it's like, okay, now what do I do with it? But
Mm-hmm.
again, I really try to kind of push for people to go see my nutrition people as much as I can,
Mm-hmm.
because I want them to kind of to help with all of it.
I know that you are an expert in sexual health and wellness, and I want to end our podcast episode on that information and how weight gain affects women in terms of their sexual wellness.
So, okay, sorry again. Say that one more time. Sorry.
I
Repeat.
know that I know that you are an expert in sexual health and wellness. And so we're sitting here talking about the perimenopause phase, midlife women, gaining weight, not feeling great about themselves, and how that affects their overall health, their sexual health and wellness.
Absolutely. So when I look at a female with sexual health and wellness issues, I really kind of take a very biopsychosocial lens. So what that means is that first of all, when they come to me and say I'm having some issues, like I want to make sure, is it a pain issue? Is it I love my partner, but I just am not feeling arousal, libido changes, orgasm issues? There's so many parts that play into sexual wellness. The first and foremost question I always will ask is, do you like your partner? Because if you don't like your partner, then that's going to go in a different direction on what I can help with. But there are so many parts that go into the female. So it's a funny conversation like I had with my husband this week because I was having some anxiety over some things, and he is a military person. So he's really good at compartmentalizing. He's like, Heather, just take it out of the back of your head and put it over here. Like, just do that. And I am not good at compartmentalizing. I usually, for no pun intended, and it's probably because I have a pilot husband, I like to refer to females as a cockpit. And I know that's, or the flight deck is what I'm supposed to say, and men as a light switch. And that
Mm.
all the moving parts and pieces, and men are this on-off trigger. So let's say the house is a mess, you're having a bad day at work, kids have done something to irritate you for the day. The last thing on your mind is sexual health, and your sexual wellness. So even though your partner may say, hey, a great orgasm is going to make you feel great, like that's the last thing on most women's minds. And I also will tell women, sleep, sex. When you balance it out on a scale, sleep's going to win that equation every single time. And then when you add
Mhm.
in that you may not be feeling like yourself in your body, so you're having mood changes, you're having memory concerns, you may feel like you're more abdominal belly fat. We put so much pressure on women to look a certain way, act a certain way in society, and we bring all of those emotions in with us, whether we want to or not. And so if you're not feeling great in your own body, the last thing you want to do is get naked with somebody and have this sexual experience, and feel like it's going to be great and normal. The other thing I want to add when I'm talking about sexual health, especially in long term and in particular heteronormative relationships, for example, is that we get into this phase of life called the heteronormativity of sexual desire. There's actually an article that was written about it. And what it looks at is that we go through what are called spontaneous and responsive desire. And so as our body changes and as you're in more of these long-term relationships, it may not be that spontaneous desire and that chemistry that may have brought you together initially, where I say it's this firecrackers and moonbeams and you're just ready to go.
Mhm.
And it has to move to more of the responsive desire where you're like, I actually really like my partner a lot. I feel great. Maybe we'll be more intimate, but I have to be thinking about it. So I always will say, like, date your partner again, or what are your acts of love or things that maybe get you aroused. So if your partner knows that it's having a clean house, maybe washing the dishes, taking care of the kids for a night, giving you some downtime, those are all things that people need to talk about in the relationship, and how it kind of pertains to this whole sexual wellness in midlife. I mean, we could do a podcast in and of itself on
Oh, yeah, of course.
sexual wellness in the midlife time frame.
I just had a thought go through my mind as you were talking. When a woman is optimized with her hormones and you're working on that with her, and at the same time she's taking a GLP-1, does the GLP-1 cause any loss of libido? I would think that it does because I've heard that many women feel, and men that I work with feel very tired on it. And that could be just the medication. It could also be the lack of nutrients, lack of movement.
Yep. So we need more info. I'm actually submitting an abstract for the International Society for the Study of Women's Sexual Health this year on the use of GLP-1s with sexual side effects. When we think that the medicine actually does really calm the hunger chatter, we're looking at this medication. It helps with alcohol cessation, smoking
Hmm.
cessation. We've seen studies showing that it has helped. Why would it not have effects on sexual health? So
Hmm.
if we're noticing that you're not feeling like you need to go binge alcohol or smoke, then why would it not flatten out the libido? Libido is triggered by those excitatory neurotransmitters. So your
Hmm.
dopamine, your norepinephrine, and all of those things. So if it is calming it down and calming down the chatter, then it absolutely, in my opinion, and anecdotally, 100% in my clinic, I am seeing it. I'm starting to get what's called a DSDS, a decreased sexual desire screening on my patients. It's just this 5-question thing. And yes, and I've even seen it in the Reddits and things. We just need more information. And so
Hmm.
it's part of my goal for the abstract I'm submitting is we're going to do a literature search, and then we're going to go back in and do some qualitative analysis in my clinic
Oh, that'll be really interesting.
because I think there is 100%
Yeah.
a correlation. That's
Which
just
is so frustrating, right? Because women are listening to us speak and they're listening to you say, over in here in this bucket, we've got all of these tools to help lift you up and get things started again, right? And then we have another bucket that might take things in that bucket down a little bit, right? And it's
and
very
that's why
frustrating.
And that's why I like the lower dose microdosing
Yeah.
you can on these GLPs so that you don't have such a strong reaction of not wanting to eat, not wanting to have sex, not feeling like yourself. And that's why I think, again, it's really important to actually see a healthcare provider in person who's going to manage through these symptoms rather than these doc in the box shops that throw you your peptide and you never talk to anybody because
Yeah.
there's so much more to this medication. And I think they're very powerful tools, but powerful in a very good and a bad way too.
Yeah. Well, Heather, this has been a great hour-long episode with so many golden nuggets to end on. A woman listening, what are your 3 top action steps that she can start doing today if she's struggling with perimenopause, in perimenopause with her weight?
So, my actionable steps for a woman is first of all, if you feel like you are experiencing some changes that are going on in your body, the first thing is listen to yourself. Nobody knows your body better than you. And if you are getting dismissed by your healthcare provider or you're not finding someone that can help you, go to the different societies, the Menopause Society, the International Society for the Study of Women's Sexual Health, or get on to different podcasts. Jill, your podcast, my podcast, the Just Ask the Kelly Casperson, You Are Not Broken. There are so many people
Hmm.
that we follow and that we can help you to get the tools in your arsenal to see someone. So that's number one, is that if you're experiencing these changes, listen to your own body. Number two is don't be afraid to take hormones. I think that hormones have been really villainized, and I think that you really need to find a healthcare provider that's going to work with you through hormones. They should be a gold standard in perimenopause and menopause care, but I think we've put so much fear behind them with the Women's Health Initiative, and a lot of the debunking has been done by it. But I think we're still there's still so much misinformation that's out there. And number three is I want you to be good to yourself. I want you to take the time for meditation and mindfulness and all the
Hmm.
things that we are bad at. Slow life down a little bit and realize that it is okay to prioritize yourself. Because as women, I think that's one of the worst things is that we care for everybody before we care for ourselves. And like someone told me, as I've been going through some things the last couple of weeks, the car does not run on crude oil. You need things in the tank to really keep it going. And when you do not have gas in the tank, it is not going to run.
Yes, and also that this is a process, and this is about longevity. It's about making the choices today that are going to be sustainable for the next 10, 20, 30, and 40 years of our life, which are going to be fabulous for us all. And it's going to take mindfulness and intention to make all these healthy decisions and align yourself with providers. I always call it building your healthcare team, and it looks really different for everybody, right? And that includes a provider like yourself. It could include a health coach, a fitness professional, could include a therapist, a PT, a pelvic floor therapist, like all types of people. And building that healthcare team for yourself is going to help you move through all of these decades of life.
Absolutely.
Yeah, well, Heather, thank you so much. It was great to see you again.
Likewise. Thanks for having
And
me.
yeah, and I hope everyone enjoyed the podcast. And there's so many golden nuggets. I'll connect all of your social media and website information in the show notes for everyone to contact you and follow you on social media and listen to your amazing podcast. And again, everyone, thank you for tuning in.
Thanks for having me.
Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.